about the echo. I think that obviously would have been a very timely didactic, and so I'm not sure what the members of the group have been seeing, but I can certainly tell you from a state perspective, there was really no indication that that was going to happen. We kind of found out on Tuesday morning. Similarly, we jumped, into action and were able, obviously followed the recommendation of the FDA and CDC to have an immediate pause. All the doses of Johnson & Johnson were accounted for and started making immediate arrangements to offer Pfizer or Moderna to those sites. The Advisory Committee on Immunization Practices met yesterday, and they recommended to continue the pause until there can be further information received. The pause was due out of an abundance of caution because there were 6 reported cases of central venous sinus thrombosis, which is a pretty rare condition, but there were 6 cases noted in 18 to 48-year-old females who had onset of symptoms within 13 days. There had been 7.2 million doses of the vaccine administered, and there had been a few cases. 4 of the 6 cases had thrombocytopenia or low platelet count. 2 cases, they did not know what the platelet count was. 1 individual was a smoker. None of the 6 cases had a history of coagulation issues. For what ethnicity data we have, 2 of the 6 were white women. None had a history of oral contraceptives, there was 1 additional case in a 25-year-old male that was noted in the phase 3 clinical trials. But because of this, they recommended to have a pause out of an abundance of caution. And so I think everyone, I was on a call yesterday with Paul Wofford and Atul Gawande, and I think, the concern from a state level is, there was already some question about Johnson & Johnson because of the massive amount of doses that were lost, 15 million doses. And now this report, really the message should be, this is why we have these safety monitoring systems in place, that, this is why we monitor and continue to monitor. But as Dr. Offit said yesterday, that would be what I think would be said, if we weren't in this climate of so much vaccine hesitancy. And so I think it's going to be a challenge. This is why we monitor. There may not be any true association, but until we learn more, and that's why they did this. Peter Marks said in the initial CDC, an FDA joint press conference, Peter Marks from the FDA said that, this could still be a risk-benefit this discussion because it wasn't a mandate, it was just a recommendation to pause. But our state did take, as many other jurisdictions have, a pause on all Johnson & Janssen administration. So I'm not sure what I would be interested to hear those who are in active practice, what type of calls you've been receiving are. Anytime there's a big information like this, we always discuss with our public information lines. The coronavirus hotline is what handles most of the medical type questions associated with the COVID-19 vaccine. There's the COVID-19 vaccine info line that's more about access of the vaccine, but we have, seen an uptick in questions, individuals. The messaging is if you're a month out from your Johnson & Johnson, it's you're very low risk. Usually the symptoms presented within 2. So the question or the symptoms, I guess, for patients to be monitored period, typical symptoms such as in the legs, but then also noted headaches, given this was, a venous sinus venous thrombosis. So I think that we'll be seeing individuals call, and certainly something as healthcare providers need to be aware of, because people are going to be calling about these symptoms.
Thank you so much, Dr. Costello. We were having some audio issues towards the end there, but it may be if you have a cell phone nearby or another tech device nearby, but we were able
Sorry,
to...
I'm actually traveling, so I do apologize. You know, those country roads, so I apologize.
Absolutely, no worries at all. Just travel safely. And thank you so much for addressing that. That was certainly something a lot of people had questions about. So anyone in the group have any comments or questions based off of everything Dr. Costello mentioned? Feel free to unmute as well.
Petra, can you hear me?
Yes, we can hear you, Dr. Weiss.
You know, just a comment to excellent points that Dr. Costello made. I think in this day and age of vaccine hesitancy, which seems to be accentuating, unfortunately, one thing that we have to bear in mind is that the issue of the CVST cases that we have seen with the mRNA vaccines and also the adenoviral vector vaccine from J&J is that, you know, these are not to be really compared with the oral contraceptive risks that, you know, female subjects may be experiencing, or pregnancy. And I've seen a lot of people say, well, the risk of pregnancy or oral contraceptives are far greater than these type of vaccines. And I think the decision that the FDA and the CDC made to really pause and look at these data are right on. I mean, I think that's what we need to do. These are new technologies, new innovations. The oral contraceptives have been on the market for, you know, over 60 years, 70 years. So they have their own place in the clinical decision making in terms of their risks and benefits, and the clinicians are very versatile in discussing those risks with their patients. But clearly, in this day and age where vaccine hesitants are looking for ways to, you know, penetrate into the vaccine wall, we just have to be very careful to not exchange one for the other. And these are not apples and oranges that we are, you know, we're trying to compare. Clearly, the, you know, oral contraceptives or pregnancies or some other clinical indications that may have a risk for CVST are different than these new generation of vaccines we are facing. So we have to approach it through a large viewfinder, investigate it, and then come back to the public and provide adequate information that hopefully put their anxiety to rest.
You know, I think those points are excellent in the context of, I'll say, rich Western countries. And when you look at the different vaccines and the vaccines that need to be used around the world, it's difficult or impossible for the very large populations in pretty much all of Africa and most of Asia to use the mRNA vaccines because of the cold chain, and there's 2 doses instead of 1 dose, and so on. Again, I get most of my information from like the radio, right? NPR or other news sources, and because it's kind of hard to get them anywhere else. I usually read Wall Street Journal, and I get the daily, whatever, updates from different newspapers. But I mean, gosh, there's no really medical stuff that you can look at this quickly. So the deal is, I mean, so I think in Africa, they bought like reserved something like 2 billion doses of the J&J or the AstraZeneca vaccine, and ditto in Asia. You're talking about basically 1 of these events per million doses as Dr. Costello said, that the normal, usually the people who have the side effect of the headache and malaise and stuff like that, that happens either immediately in the first 2 or 3 days. And all of the people who had these serious complications, they started getting their headaches 7 to 10 days later. And so there's a way that you could say that, okay, I think I'm having a more severe reaction. And for us, that's fine. People are like, oh, I don't want J&J, give me Pfizer, give me Moderna, and so on. And meanwhile, in Africa, where I've heard both that the Africans have I've heard that they're both lower mortality rate and higher mortality rate. It's kind of hard to sort out. I know in America, the African Americans have higher rates of complications with COVID, but maybe in Africa it's less. Nevertheless, you're talking about one serious outcome per million vaccine doses versus an overall efficacy of for J&J, 64% for preventing infection. I'm not sure if it's 90 or 95% for serious outcomes. But gosh, you're still talking about untold lives saved. And what they were saying is that whatever decisions are made by America influence the advice that many of these other countries are going to be giving. And so I think it's such a funny responsibility, right? So we have our own issues here with vaccine hesitancy on the one hand, some other vaccines which have even better efficacy than these others, but then what's our responsibility to other countries, other continents, and so on about giving those kinds of judgments really about the vaccines.
I think that's such an important point because maybe, it was interesting when we've done some data analysis, what we saw early on, people really weren't saying, they didn't need to know about the complications of COVID because we had all these high cases and people were so worried about COVID. And now that we were seeing less cases, obviously now in Michigan, we're seeing increased cases again, which is, certainly more the variants, but there are serious complications from COVID, including even clotting diseases. So as Dr. Weiss mentioned, these are such rare events, we seem to forget about the severe complications. Even in children, there can be severe complications, MIS-C cases, we have had multiple echoes on that. And so with any vaccine preventable disease, I've never seen a case of Hib epiglottitis in my career, but Dr. Weiss, I'm speculating that you have, but I trained more in a vaccine preventable when that was a vaccine preventable. So as we've seen the vaccine be more effective, some people I think have seemed to think, and we've even seen that in West Virginia where people initially would sign up for a vaccine, they would call to be with appointment and said, oh, well, there's not really COVID in my area anymore, so I'm not going to get vaccinated. So we come like a victim of our own success, but I think we need to remember the serious, dangerous complications of COVID as well. And this one event, 1 in a million, again, I agree. I think I do worry. And I think that we're going to have some challenges. We don't know yet in West Virginia if we've seen a bunch, but in a call I was on yesterday with multiple other states, they had already started to see a significant no-show rate in their vaccine clinics since the J&J announcement, to the level of 25 to 30% no-shows of their larger vaccination clinics in places like Boston, Texas. So, I do worry that this could have even longer standing effects. And I think all the global points Dr. Weiss mentioned are really, really important to be cognizant of as well, that, COVID is still a serious disease and we're really in a race with the variants because we're seeing way more variants here. And so it's going to definitely be a increased challenge now to overcome some of the challenges we were already starting to experience more with more vaccine hesitancy.
Thank you all so much. That's a huge percentage. I wasn't aware of that, Dr. Costello. Thank you. Any other comments, questions, thoughts?
Hi, this is Dr. Himanshu Paliwal. I have a question is that at workplace, I'm talking about more like healthcare staff. I mean, is your department or the hospital or the clinic is doing anything different, like to get all the healthcare people vaccinated? I mean, most of the time, the healthcare providers know all the ins and outs of vaccines and things like that. Okay, but they are still reluctant. And part of the reason is the same thing. If we don't see COVID, we don't see people sick in front of us, we don't feel it is serious. So I was just wondering, any of the department is doing some incentive, disincentive, some kind of thing to address it? Thank you.
I can start to address this. Certainly, I agree. I think that, you know, we in certain areas there is less uptake. For instance, in our long-term care facilities, staff uptake was around 50%. Resident uptake was closer to the 80% range. And so I've also seen that in hospital settings as well. Some of the work that I can tell you the state is embarking on, last week, we held a webinar that there was CME offered to try to build vaccine confidence, not only with our patients, but even with your healthcare workers. The CDC does have slides that you can give to staff themselves. There will be another webinar that the West Virginia Immunization Network is hosting next Wednesday, where members of the Public Interest Communication Research Lab through the W. Reed College of Media that have been instrumental in our state's response, they'll share some strategies based upon perceptions and intentions to be vaccinated that we're seeing in West Virginia. So we're trying to do some more targeted outreach to healthcare professionals, but it is certainly an ongoing challenge. And I think the big areas, it does tend to be more females of reproductive age, where we hear that people don't want to be vaccinated because of the concerns with reproductive health, even though you know, there's no indication that, you know, there is any impact on a person's ability to become pregnant. So there's been some targeted outreach, and as a state level, we're trying to have more resources that can be used at the local level. The one thing that's been consistent throughout our research that we've been able to perform from baseline before a shot was ever in an arm in West Virginia till now is that a local health provider is the most trusted voice. And so I think it becomes on at the local level that we all arm ourselves with knowledge, pun intended, to be able to have these conversations, listen with empathy, you know, hear what the person's concerns are, and then provide evidence-based recommendations and make that strong recommendation as a healthcare provider that, you know, that someone should choose to be vaccinated. And I think that's really where we're going to be able to build more vaccine confidence. It's not really going to be through probably a podium or something of that. It's going to be these individual discussions and listening to hear what we can do to try to build more vaccine confidence. So there will be some additional targeted resources coming out specifically for healthcare providers. But in regards to incentives, I've heard a couple businesses like offering incentives. I think that's a slippery slope. You have to be careful with that. Just like fear doesn't work to build intentions in this situation, you know, fear could actually deter. So sometimes if people feel like, you know, they could lose their job or lose some type of compensation by not being vaccinated, that's not really a good tactic to use. It's better to try to build that confidence. And so that's all that I have heard, but really I think it's you know, there's been some discussions, I think colleges have talked about mandating the vaccine, but I think there's been discussions, but no confirmed in anywhere in West Virginia.
So I don't know, I'm not sure if I know how to raise my hand like on Zoom. So I raised my hand. If Dr. Costello and I are talking too much, Mithra, just mute us, or somebody else let us know, okay? We'll be happy to stop talking. One of the things is that, you know, the FDA has approved these under its emergency use authorization, right? So I'm reading right now from my screen here from the FDA.gov site, what is an EUA? It's a mechanism to facilitate the availability of vaccines, drugs. So the FDA may allow the use of unapproved medical products or unapproved uses of approved medical products and so on. So in some respects, these are not approved. Now they are approved. So this is something else from the FDA, is that these are approved, but they're approved under emergency use. Well, I have a daughter who is a pediatrician in the Navy station down in Florida. And on the one hand, military people are being deployed to go help with set up vaccines and so on. On the other hand, even in her own clinic, some of the corpsmen aren't vaccinated. And so she tries to convince all of her corpsmen to get vaccinated. So, I mean, I was in the military for almost 30 years. And whenever I went somewhere, nobody asked me if I wanted a vaccine. They said, line up, roll up both sleeves, you're getting a bunch of vaccines. So I got yellow fever and typhoid and, you know, every JE and everything else you can think of. And nobody ever asked me. For this one, they're asking the military personnel if they want it. I mean, it's more or less everyone's going to get it unless you decline. So there is something different about this vaccine than, for example, the annual flu shot, where in the hospitals we say you have to have a flu shot if you want to work. If you cannot have it for a medical reason, you must wear a mask. Well, now everybody has to wear a mask anyway, right? And so I think this one is a little bit different. The thing that I think many of us are frustrated about is that in our hospital, we have medical education, which students and residents. We have morning report, which are the pediatric residents and the pediatric attendings. And while Zoom is helpful, like for all of us, I mean, gosh, you couldn't get all 19 of us into a room. There's too much travel, there's too much this, there's too much that. So it's helpful, but on the other hand, for education, it's much better if I'm sitting in the room with the interns so I can look at their face and see if they look confused and like, oh, let me explain that better. Or I can call on somebody and say, hey, I want you to give a quick summary of what I've just told you so I can make sure you understand. Hard to do on Zoom or WebEx or something like that. So we have asked, listen, if the residents and the faculty have all received 2 vaccines, it's been at least 4 weeks later, why can't we all sit in the same room, even with our masks off or even with our masks on? I don't care, right? But sit in the same room. And the 2 people who have the most experience with infection control in our hospital are saying, yes, we should be able to do that. But some of the decision makers are saying the CDC has not addressed that yet. So until the CDC addresses it and gives their okay, the people that we have who work here, who in my opinion are smarter than the people at the CDC, and you've had these people here on this, right? So you know who they are. We're still not able to do that. I think, you know, there's been a talk about passports, right? And initially, I think on the federal level, there was a big push for passports. Anybody who's had 2 vaccines and at least 3 or 4 weeks has gone since their second one, or if they had the single dose vaccine and enough 3 weeks have gone by. There's something on your phone from the federal government, the CDC, saying this person has been vaccinated. And no, it's not 100%, but it's darn good. No one who's been vaccinated, and Lisa, correct me if I'm wrong, no one who's been vaccinated has died of COVID, right? And so why can't we say, you have the passport, you can go to the restaurant, you can meet in person, you can have educational conferences in person, you can do this, you can do that. And that sort of thing would be such a great incentive, Dr. Pollywall, I think, to get people vaccinated. If we say, we want you to get vaccinated, but nothing's going to change, you still got to wear everything, you still have to do this, you still can't be in person, then, and you have just a tiny little bit of hesitancy, like, well, screw it, I'm not going to get vaccinated. It doesn't help me, right? So anyway, I'm now going to put myself on mute. I thank you.
Thank you so much, Dr. Weiss. And I just have to say, I loved your manual hand raise feature, and Elizabeth chatted in as well how to do that. But I did really love your manual one.
I'm old. That's what I do.
I love it. Dr. Pollywall, I do see that you raised your hand. Did you want to go ahead and unmute, or were you just testing that out?
No, I mean, if nobody else has any other question, one of the reason I am facing the question is, as of right now, if a healthcare worker who is unvaccinated and get exposed to anybody with COVID, and it's a significant exposure, it still recommends that the healthcare worker should be off, should quarantine for 14 days. And again, many of the time it becomes a very difficult to follow. That is one thing. And again, we are going to face this COVID for next couple of years, the way I see it. Okay, so it's going to be a recurring problem. The second thing is the risk of fellow colleagues who can get infected when this unvaccinated healthcare worker gets sick is another risk that we are taking. So that is the two other things that is coming off from that question. Thank you. I appreciate Dr. Weiss.
So one of the things that I have heard about that, at least of some that are considering, is that, if you choose to not be vaccinated and you have an exposure and you have to quarantine, that comes out of your sick days. And if you don't have sick days, then that would be, a personal cost. Now, I think for larger scale places, that's probably easier to have something like that. If you are a small practice and you have few employees that choose to not be vaccinated, you either keep your office open or not, and they do have to be quarantined, so it does become a trickier situation. But I certainly think that's going to be something, and as we think that they're effective against the variants, but we're still learning about that, and it really is truly a race against the variants, where I think we just don't know yet. And I mean, most people have speculated, we're not going to be able to get to levels of herd immunity until we start vaccinating children. Now, we, with last week's submission from Pfizer to move down to age 12 to 15, I'm hearing that will be something that the FDA considers in the amendment to the authorization. It's not likely going to go through VRBAC or any of the other committees. So, there is potential that we could start vaccinating children down to 12 years of age, soon, but it's certainly, time's going to tell. But as you said, I think that this is something that, it's been a long haul thus far, but we're still going to be dealing with ramifications of this pandemic, and it's going to be an ongoing adaptation as we continue to see how this plays out, and to see how well the variants do, and which ones. We had our first case of the South African variant last week, confirmed in West Virginia. The B.1.1.7 still certainly remains the predominant variant that we're seeing in West Virginia. But I don't know if other people have anything to chime in from what they're seeing, you know, any other suggestions. It's, you know, certainly I think there's going to be more discussions. Rutgers, as I said, and Notre Dame are mandating the vaccines. You know, there's been the question of, can you mandate a vaccine that's under emergency use authorization? I think individuals have stated in public health, you know, some states have felt that they can. I have worried about that in regards to, you know, as we need to learn more and under an authorization, I think there's individuals who are more hesitant to do that as making it a mandated. That's why I think really it's going to be important to try to build more vaccine confidence so that individuals choose to be vaccinated on their own. And if we can help to improve their intentions to make that choice.
Thank you so much, Dr. Costello. And Dr. Wertz, I noticed you raised your hand as well.
Why, thank you. Sorry, I don't have a camera today. I'm over in my NIOSH office where they don't believe in cameras. And so I have two questions. One, I think you sort of addressed, which is for the people who seem to be having the blood clots. I mean, that's a known side effect of hormonal-based birth control. You mentioned not birth control pills, but I was curious because there's a whole slew of other ways to do hormonal birth control at this point. I was curious if that was something that was known about the people who might have gotten the blood clots, and you know, because obviously that would be a easily targeted reason population not to use the J&J vaccine in. And the second thing I was going to ask about was you just touched on it after I put my hand up, but I want to ask a little bit more depth, which is, you know, it seems like in the next couple of weeks we will probably have authorization to use the at least the Pfizer vaccine in people down to age 12, or at least that's likely. Is there any, because I know Dr. Costello, you hang out at the state EOC, is there plans afoot to do that? And do you expect that that'll be done through the schools, or will that be a community-based effort like we've done so far? Over.
So I can start. I can take the second one first. Yes, I think that we have been planning as you know, being a pediatrician, this has obviously been something on my radar. So we will continue to use our multiple ways to administer vaccine. We already, when we have been determining our state allocation, we get a proportion allocated to us of Pfizer, Moderna, and Johnson & Johnson. As we've seen use, it slowed down in certain areas. You know, we have always indicated that we would take our max amount of Pfizer, even if we weren't allocating it, in anticipation of being able to have supply to administer the vaccine. From the call I was on yesterday with Dr. Offit, Moderna's data, you know, they've been studying, now Pfizer and Moderna have been studying down even to 6 months of age. There is, you know, the thought that Moderna likely within the next few weeks, they're just waiting for data. They had some challenges getting the numbers needed in their trials. So the state has been actively planning. We will likely use our school or work with our education partners through school-based health centers and pharmacies to go to schools to administer vaccines, as well as the whole of community vaccination clinics. We will eventually start seeing movement into provider offices, you know, those who care for children and otherwise. The problem is exactly what Dr. Weiss touched on earlier. In global markets, you know, these vaccines, the mRNA vaccines, are logistically challenging. You have to have special storage. We've seen some healthcare professionals not want to have the vaccines in their offices because of all of the additional equipment that may be needed, that, you know, particularly the ultra low cold. Moderna has, you know, kind of been able to see that you've had some changes, not as strict, but right now, you know, Moderna is not available for age 12 years old. So the state is already planning. We're looking at, you know, how that would be distributed. It will likely be through schools, so similar to how H1N1 was done and what we're already doing in our 16-year-olds. But I think it's going to be incredibly important, as we've been talking throughout. You know, we really have to try to build vaccine confidence, because at least what we're hearing from public sentiment and what we're seeing in numbers, you know, there are parents who are reluctant to have their children vaccinated or their adolescents vaccinated. So interestingly, the parents will choose vaccine for themselves or for other adults, they will recommend it. But when it comes to their child or their adolescent, they're less likely to choose to be vaccinated. So we certainly have education that we need to do there, and to emphasize that children can get serious disease. We've had, hundreds of pediatric deaths from COVID. MIS-C does have long-term complications. We've seen in athletes, individuals who have contracted COVID potentially have cardiovascular manifestations. So there are secondary impacts in children. So it's important that children are vaccinated as well, even though, yes, adults have bear the brunt of the disease. So that's the second part of your question. I can pause. Does anybody else want to take the first one, Dr. Weiss, since you're another hub member, or I can keep going, but I'll pause there because certainly I think the pediatric one is important. Then we can go back to your first question.
I think the pediatric part is, let's say, potentially problematic because both the MIS-C as well as some of the other complications in younger adults, not the geriatric population, it's because of immune cross reaction, if you will, right? So it's not of all the kids that we've had here in our hospital, in Children's Hospital with COVID, we've had a handful with COVID, maybe 3 or 4 in the ICU, 2 or 3 needed to have respiratory support, but they all went home like in 3-4 days. And it's the kids who had the COVID who have the antibody, right? So now we're giving vaccine, and we're going to have a bigger population of people who we've given antibody to. So that's why we're doing all these studies. That's why it's important. Not like in the olden days, we would just approve medications, vaccines for adults and say, I'll give them to the kids. And now we need to do studies on the kids. And like Dr. Costello said, we are doing the studies in the kids. And it's not just like, oh, well, here's a protective level of antibody, whatever it is, 20 micrograms per whatever, but we have to say, oh, are 30 days out, 45 days out, are they having any other complications? When we have that data, then I think people are going to be much more willing to have their kids vaccinated.
Thank you to both of you. And Dr. Werntz, could you kindly repeat the first question that you had as well, unless it was already addressed, but I wanted to make sure it was addressed for you.
Well, no, thank you very much. No, I'm very interested, as a medical director for a couple of camps, I'm very interested in how we get our youth vaccinated as well. And so the other question I had was for the people who are having the blood clots with the J&J, you mentioned not on oral, there was mentioned that they weren't oral birth control people, because we know that that's a risk for the exact same kind of blood clots. But I was really curious about all the various kinds of hormonal birth control, because I don't know what the ratio is, but there's a whole bunch of other forms of hormonal birth control that are not birth control pills. They're patches and rings and inserts and injections and all sorts of different things. I was just curious if that statement that they weren't on oral birth control included all those other hormonal things, which I think is about half the market.
Yeah, I'm not sure. I think that's probably why ACIP wants more time so that they can get more information about these cases. From what I was shared, there's been, I'm looking at some notes that I did not admittedly get to watch the ACIP meeting yesterday. I think they're still finding that information out, but I haven't seen if they distinguished between if it was only oral or if they were on any contraceptive. So I don't know if anybody else has any further insight on that.
Thank you, Dr. Costello. And I know you have to hop off here actually right now, 1 p.m. for another meeting. So we truly appreciate you being on here today.
Yeah, I'm sorry I have to go, but thank you again for hosting all these and for all the great questions. But thanks again.
Absolutely. Thank you, Dr. Costello. We'll see you next time. So I'm not sure if anyone has any other thoughts or maybe a response to that, but it might be more to come in the future. Dr. Werntz, was that everything you had for your question as well?
Yes, thank you very much. Those are my big questions. I'm really curious about kids, but I said that'll be a work in progress.
Absolutely, thank you. And we did get a chat in asking about everyone's thoughts on building vaccine promotion campaigns for children who could be great advocates to pressure their parents to vaccinate. So I didn't know if anyone had thoughts on that or anyone wanted to expand on that. We do have about 15 minutes left here, but we do have that brief poll. So if there are no further questions, we can always build a queue of questions. Feel free to email me or Elizabeth any comments or future didactic topics for the future that you'd like to hear. So if there are no further comments or questions, I can just launch the poll. The only announcement I do have is that our next session will be on May 6th, and we are moving our sessions to monthly. So it'll be the first Thursday of each month. So let me launch the poll here. Is everyone able to see that okay? Awesome, thank you. And thank you all so much for joining today. We always enjoy these sessions so much, and it's thanks to all of you guys. And thank you, Dr. Weiss, as well, for hopping on here today, and hopefully you can join us next time as well. Thanks, guys. And anytime you finish these poll questions, just feel free to log off. Thank you.